Assalamu alaikum. Let's resume our second scientific session. I hope you all enjoyed your lunch. Next, I would like to invite Professor Tas Qureshi. He's a consultant surgeon at University Hospital Dorset in the United Kingdom and visiting professor at Bournemouth University. He was appointed as a national trainer on the LAPCO training program and has run international laparoscopic masterclasses all over the world.
अस्सलाम वालेकुम। काश मैं ये टॉक उर्दू में कर सकता, लेकिन उर्दू में करूँगा ना तो आपको सब टाइटल्स चाहिए होंगे, इसलिए मैं इंग्लिश में ही करता हूँ। अच्छा, ये ज़रा ऑन कर दिया। इसको डिस्प्ले करेंगे। चलो पता क्या, टॉक कैंसिल कर देते हैं। हाँ, about that. चल तो रहा था, वो तो मैंने भी किया। हाँ, आ गया। Okay, so I'll start my talk just to give some context. There's been a lot of people saying that, you know, things are very difficult in Pakistan and there's this in Pakistan, that in Pakistan. Just for the record, we've had meshes taken away in my hospital for hernia repairs, so it's not just Pakistan. We had our staple guns taken away from our hospital and replaced with Chinese staple guns with no choice from the surgeon. So, you know, you always think grass is greener somewhere else. It's not always greener somewhere else. And, you know, let's talk about the positives. There's so much positive that's here within Pakistan, having spent so much time here. So I should start my talk just by saying a thank you to the organising committee for the invitation, to Professor Amjad Siraj and to Khurshid and Mujib and everybody. The title of the session was The Future of Surgery, so I've a bit of lateral thinking, so I thought we'd just go through what we're doing now and what might happen in the future. So, you know, a few years ago we would have said that this is the future, but actually this is the present. And most of you will be familiar with this, but just for the sake of the trainees and others, I'll just go through things again. You'll be familiar with the Da Vinci robot. In the middle, you've got the nerve center of the robot. On the left, you can see there's the patient cart, and on the right, as the surgeon, you sit remotely to the patient, so you're at the surgeon console. So like anything, there's lots of strengths and weaknesses. So what are the strengths? The main strength is it's a very precise tool. And really important, when you're working in a small space, that the human hand, small movements cause a problem. So what the robot does, it downscales your movements and makes it much easier to work in a smaller space. And of course, as you get older, a bit of a tremor develops, and it helps with the tremor as well. But there's huge weaknesses. And the weaknesses is it's not cheap. It's a very expensive thing. I don't know if you remember, the older people in the audience might remember the original mobile phone used to be like a suitcase. And now look at the mobile phones, they're tiny things. So I'm sure we're going to look back at the Da Vinci robot and think, you know, how on earth were we operating on people, because it's such a large, intrusive thing. And you know also there's no haptic feedback, there's no tactile feedback. So what's the USP for the new robots? Well, basically it's size and cost. That's the only way they can try to compete with these people. So it's about downsizing, isn't it? It's about getting rid of the bulk of the robot and getting something much smaller. And these are the sort of robots that are potentially out there at the moment. There's the CMR, which I understand there's a few CMRs in Pakistan. And then there's tiny robots to help with the cornea. And the new generation Da Vinci robots are single incision. So you have one incision and all the instruments come out through one port. So that's the future, isn't it? Now, I mean, this is a couple of slides, years old, this slide. But my point is, we're around 2017. And at the moment, the robot is remote controlled, i.e. the surgeon controls the robot and that's how the operation happens. But in the future, the direction of travel is that maybe the robot will be autonomous and operate on itself. Is that possible? Is that likely? It's a question that most of us surgeons dread and fear, but you know, I don't think we're at risk just yet. But at the moment, there is software out there which tracks the surgeon's eye movements while he's operating or she's operating. And tries to predict the surgeon's moves. And actually, this is a robot that autonomously just can do an anastomosis. So, you know, we shake our heads and say, no, never. You just never know what's happening around the corner. To be perfectly frank with you, 10 years ago, if you said I'd be working with a robot and using a robot, I wouldn't have believed you. So, you know, time doesn't stand still and technology doesn't stand still. So maybe this is a future robot. So while this plays, you know that, I'm sure you know, that the robot is a military invention, the American military. It's like the sat-nav was an American military invention, and the point was to extract the casualty, to damage control surgery, the casualty, and take it to the field hospital, which is where the surgeon would be, so to protect the medical resources. And that's how the robot started. And then you know that the civilian surgeons caught wind of the fact that actually there was this tool that might be quite useful in civilian life, and that's how Da Vinci came into being. So you get the idea. The robot is just damage control surgery, and then that patient's going to be medevac to the field hospital for more definitive surgery. So what about medical technology? You know, this is where it's, you know, it's quite exciting what's happening at the moment. And again, like I say, we can shake our heads and say this may never happen, but it's happening at the moment. No, it's good. I think they're trying to tell me my talk's finished. The applause started. I won't take that too personally. Okay, so let's hope this one works. Yeah. So look, I'll just play this. I don't know if this sound will play. It's not playing, never mind. But just have a look at this scan. Okay, this is what we're used to, but just see how this story develops. Okay, so we're used to two-dimensional scans, but how about this? Okay, you've got a virtual reality three-dimensional scan generated from the CT pictures, and using this Oculus tool, you can find any solid organ and find the tumor within the solid organ. So, you know, this sounds like it's crazy, and some medical schools are actually using this sort of technology to teach patients, teach medical students anatomy. So, you know, this is where technology may be going. Similarly, you know, using artificial intelligence. Can you see through the skin? No, not without an X-ray. But how about this? I'll just let this play for a second. I did a bit of breast surgery, and the number of times that we had to take patients back because the margin was involved and re-excision of the scar. So these glasses, these high-tech glasses, can actually, in real time, tell you the dimensions and the 3D evaluation of the tumor. So it helps you take out the tumor more precisely and cleanly. These are things that are there at the moment. This isn't the future. This is actually what's happening right now. This just needs to be developed. Okay, so you get the idea. 3D printing, I suppose this is another way of saying simulation. So the patient scans are used to 3D print the solid organ that the cancer's in this case it's the kidney, and actually put the tumour within the 3D organ, and then to operate in it and just figure out where the best manoeuvre, I could have used that yesterday, I have to say, but it will tell you where the best, what the best approach may be to take the tumour out. Maybe that's the future there. Now, simulators, we talk about flight simulators and pilots a lot, and somebody was asking about simulators, and when I got onto the plane in England to come to here, if somebody had said to me, well, this guy, he's done a couple of hours flying, he hasn't been on the simulator, but he should be okay, I probably would have walked off the plane. And we've got to remember that we have a responsibility to our patients as well, and in a system where you're devoid of resources, devoid of opportunities, there are all sorts of other opportunities you can take advantage of. So there are simulators, and there are VR simulators. We're trying to develop a VR simulator. That's a bit more lifelike. This is a laparoscopic simulator, but this is unusual or unique in that what we want to be able to plug in the MRI scan of the patient into the simulator, so that actually the terrain within the picture is that of the patient, the cancer is that of the patient, so it's a unique VR simulation of that patient's cancer. A slightly more crude simulator, but this is a simulator, and it's important because it just gets you to know what the different bells and buttons do on the robot, and it provides metric scores, in this case 57%. So that metric data you can follow and actually show that I'm becoming proficient at this task and move on to the next one. I won't play this one, this is a bit long-winded. So what about the future? I mean, the future is nanotechnology. Is anybody old enough to remember this film? Did anybody see this film? Yeah, there's a few shaking of the heads. For the very great majority that don't remember this film, I have never seen it. There was a scientist who had a blood clot in his head. And he was a very important scientist. And so it's always the Americans, isn't it? But what the Americans did is let me play the clip. So what the Americans did was they put the scientists, the medics, into this, I don't know, it's a submarine, I suppose. And they had the technology to be able to shrink the submarine for a certain period of time, 6 hours, 8 hours, or whatever it was. So what they do is they shrink these people in the submarine, and you can see the CGI isn't quite what it was now. And they're shrinking the submarine with the people in it, and they're going to be injected into the patient with a blood clot and try to dissolve the clot. So I suppose that's an early version of nanotechnology. Look at those effects. Was that very good? Okay. I'm being told it was Isaac Asimov was the author of the book, not the scientist, because he was fictional, obviously. Okay, there we go. Like I say, the CGI is brilliant, isn't it? Whoops, what was that picture? So what about nanotechnology now? It sort of exists because, I mean, my daughter had a capsule endoscopy within the last 3 months. That effectively, it's miniature endoscopy, isn't it? So how about if we could swallow robots? Can we swallow robots? Well, that's a possibility. Nanotechnology, I suppose, is where we're going here. This is the future. And the title of this of this section of the talk was the future. And maybe this is the future where you've got a nanorobot that can be injected into a patient. It recognizes cancer cells. It has the ability to recognize cancer cells. And maybe on its back, it's got a backpack of chemotherapy, and it can go and target the cancer cell and destroy the cancer cell without affecting all the normal body cells that chemotherapy clearly targets. This is another version of nanotechnology. Again, Hollywood was before itself. So there is a suggestion that this is in development at the moment, where you've got nanorobots that recognize cancer cells and go and chew the cancer and take it out. Well, believe it or not, some of these robots, they're thinking about just leaving them aside as, I suppose, the ultimate form of screening, that as soon as there's an abnormality, they go to the abnormality, and we heard about bowel polyps, colonic polyps, and maybe they'll just chew up the colonic polyp without the patient being any the wiser. So this is the future. So the slightly lateral thinking, like I say, the title of the section was The Future of Surgery. So I just thought I'd run through some ideas of we're actually living through the future and what the future might hold. But I think safe to say most of the surgeons in this audience aren't going to be threatened by this sort of technology in the near future. Just as a final thought, there's been a bit of discussion today about progress and what we should and shouldn't be doing. Look to the future. As I said, 10 years ago, if I thought I'd be doing robotics, I just wouldn't have believed you. And just leaving you finally with a thought here, that to survive, you have to be adaptable. You don't have to be really, I'm very average at a lot of things I do, but it's, finding the resource, finding somebody, finding a surgical godfather, and then just putting the time and effort in. Okay, thank you very much.